Thank you so much for the invitation and the opportunity and the hospitality and bringing back to the alma mater city. I'm continuing with my. Okay. So if we talk about pathologists are early to adapt regarding the pituitary adenomas, they are classifying it as PITNET, and that is adapted from 2021 and 22 classifications of WHO central nervous system and the endocrine and neuroendocrine tumors. Majority of them are functional, about more than 50%, and the rest of them are actually uh, non-functional with various percentages. The importance is that if we talk about microadenomas, and that is where actually the protocol has to be clearly defined, it is actually a T1 dynamic coronal that usually takes around 2 to 3 minutes, and the flow rate can be 1 to 2. If it is given with the injector, then it will be better. And the 3T MRI is preferred over 1.5T because of its greater resolution. We could have slice thicknesses which are around 256 by 256. More, it could be better. And the main reason to give contrast is that sometimes we are unable to differentiate these tumors just on the morphology of the pre-contrast sequences, and that is the main reason. So if we see that if we only advise MRI brain, it is difficult to pick up where exactly the tumor is lying. Even though if we do good resolution imaging, both in the coronal and the sagittal, sometimes it's difficult to appreciate whether there is any difference between the anterior and the posterior pituitary, even the pre and the post contrast sequences. Only the dynamic when we give, sometimes we are able to identify, yes, there is microadenoma which is lateralized to the left side and it is there. And the moment actually we acquire the spin echo sequences later on, again it will merge with the same thing and it is difficult to localize. So this is very important that we do microadenomas with the dynamic contrast enhanced imaging. Regarding the macroadenoma, the strategy will be just to about the extent, the invasion, the mass effect on the critical structures. It is usually the internal structures like cystic degeneration, hemorrhages, and infarction, and it could be compression or the optic pathways or the optic nerves. And if it is the cavernous sinus, where exactly it is going, it is medial to the internal carotid artery, or it is going lateral, or it is going superior or inferior. And if it is having supracellular extensions, whether it is going anterior and the posterior and going into the sphenoid sinuses, these are the extent actually we try to describe on the MR images. Like in this particular case, the patient has a known history of pituitary adenoma, and it has been treated, it has been given radiation. Post, after 1.5 months around, the patient presented with some blurring of the vision and vomiting. What we see here is that there is a fluid filled level. It is a very well defined lesion. Actually, if we talk about it is having fluid filled level, the cella is actually, though it is dilated, but it is not having any signs of invasion. And we need to know that these are the sequences in which we can actually identify the hemorrhage. These are the sequences in which we can identify if there is a cyst or there is a fluid filled levels. And on the GRE, we can identify, yes, it is a bleed. We can confirm that. On the post contrast, the bleed is not enhancing, and the fluid, it is not a clear fluid, and that's why it is not suppressing. So these are the information one can get from the MRI. And after that, once you know that it's a pituitary apoplexy, the patient has been given steroids, there is improvement, and followed by there has been surgery. Post surgery, it has been reported that there is still residual disease. But this is something which should not be interpreted without the prior imaging. And that is the importance that we need to know all the details which are there, what treatment has been given, whether we have the prior imaging, which is very essential for the follow-up, and whether we have the dedicated protocol that we are doing like that we have done earlier. So in this, we know that the cyst and hemorrhagic components were decompressed, it is excised, the disease was extending lateral into the left aspect, which having a subtle residual disease. Otherwise, most of them it is resected and just a packing that is there. If we talk about invasion, particularly the cavernous sinus, no classification is there, and in that, whether it is mostly medial to those particular internal carotid artery or it is going lateral, that we can actually identify. Here, if we draw the margin, which is more medially, it is grade 1. If it is again going beyond that and between the internal and the medial extent of the intercarotid margin, if it is between the disease, then it is 2, and is going after the lateral, it is coming to the 3, and if it is complete encasement like this, it is coming to the grade 4. And So, like in this particular case, it was an pituitary neuroendocrine tumor, which is ACTH secreting. It was operated. There was good regression because the adjuvant RT was also given because it was invading into the bone and other sites. And post RT, we can see that there is a significant shrinkage in the disease, but there is a cervical CVJ metastasis that has been developed that is also resected and again retreated. But at the primary site again, there is significant progression. What we see on the earlier PET, which is usually done because there is a chances that there could be metastatic disease or there could be multiplicity following that in particular aspect, what is the residual disease that is there. And what we are seeing on the PET CT, there is uptake. On the CT, we can see that there is a solid area that is coming back and then the patient is planned for proton re-RT in this particular aspect. This is again a pituitary neuroendocrine tumor, which is a mixed variant, both expressing GH and the prolactin. And if we see that, we can see the signs of the surgery earlier, and the disease is extensive, going into the bilateral cavernous sinuses, which is more in the left side. And if we can see on the PET, we are unable to delineate the anatomy, but on the fusion, yes, we can delineate the anatomy. On the contrast, we can get the amount of enhancement that is occurring in the gland. And on the bone window, we know how much destruction it is causing to the bone. So each and every modality will have its own advantage, especially planning those sequences. And what kind of adjuvant treatment this will require, whether it's a proton versus photon, madam has already discussed, and the cost of the treatment that particularly we talk about. We definitely need an MDT, and this is our MDT in the TMH that we usually do all those cases we discuss there. And then we decide whether how much is the extent, whether it's going superior, it's going inferior, it is causing compression of the optic chiasma, or it is going anterior to the sella or posterior to the sella, or the bone is already destroyed or destructed. All those findings has to be reported in these particular aspects. There could be a lot of mimics that can arise in this particular location, like the chordoma in which it is there. It is looks like that it is the pituitary gland is involved, but the enhancement patterns are entirely different. It is intensely and homogeneously enhancing. Just below that, the sella margin is actually destroyed, and this is the tumor which is in the midline. It is the chordoma that is lying there. There is another tumor where there is no appreciable sella that is there, but we know that there is a history of PEPCA thyroid, and there is a metastatic which is suddenly developed in this particular aspect. And so we can have, if we have this kind of knowledge, it is easier to identify what could be the most likely pathology that is existing. In this particular case, the pituitary was again normal, but there is a clival osteolysis that is there. There was the internal carotid artery aneurysm that has been coiled, and it was the tumor that is arising from the rest in the clival region. And if pathologists will say it is a benign monomorphic cells, neuroendocrine nature, it is the most likely diagnosis that it is the ectopic pituitary site from where the pituitary adenoma is arising. So there could be many other conditions that can involve the sella, and we need to know that sometimes it could be mimic the same enhancement, sometimes it could mimic the osteolysis, sometimes it is the extent of the disease that will help us in differentiating these tumors, starting from the fungal disease to IgG4 related disease to plasmacytoma to osteomyelitis, all can exist in this particular small area. Just to conclude that there has been a shift in classifying pituitary adenomas. Now they are called as pitnets, and from benign entity they have been labeled into the malignant coding disease management group. And the dynamic MRI is indispensable, especially if we talk about the microadenoma localization and differentiating it from various other pathologies. And radiologists should tailor these imaging protocol, whether it's coming from micro or it's coming for macro or it's coming for the follow-up, and then they will decide what is happening to these patients. We can take the help of DOTA PET if it is probably like ACTH if it is metastatizing to the other sites, and we need to measure the extent of the disease by using these classification of the Nospan CPEP extent, and we should be aware about the mimics of the disease. And this is our team. So thank you so much for the invitation. Thank you.